Much for having lunch in here so we can have this little session. We are not going to have enough time. I already know that. There's going to be so many great questions. But we have a wonderful panel of clinicians who volunteered their lunch hour to be up here and try to answer some tough questions. And we have some fantastic folks over here who are going to be asking those tough questions. So let's, I'm going to let them introduce themselves. So Rini and Dale, come on up.
Hello, my name is Dale Berg. I'm a schwannomatosis patient advocate for CTF and several CCAB, the Clinical Care Advisory Board, and a couple other CTF events. So I appreciate the opportunity to ask some really tough questions today.
I'm Rini Moss. I'm the mother of 2 children with NF1, and my husband also has NF1. I like to refer to myself as a momcologist. Thank you. Because we have to, right? That's right. Kate asked us to kind of grill the docs, literally. And so Dale and I are like, yes, of course. And so we kind of over the last few weeks have compiled a couple of questions that, have come up when we've in our own care or in the care of our loved ones or in volunteering, hearing from other families and patients. And then the questions that we think people have said we're afraid to ask, so we're going to ask them. And then we're also, if we have time, want to take questions from the audience, if that's okay. Caveat, medical, diagnostic, surveillance questions are probably private between you and your doctor, so just make sure that the questions are general and kind of meaningful in terms of this instead of kind of very private medical information. Is that fair, doctors? Okay, great. All right. Dale, why don't you go first? Because I'm going to go.
To Allison, genetics, depending on an NF1, NF2 schwannomatosis patient, how frequently would you meet with a patient and or their family over short-term, long-term, decades, few years? What's your frequency?
As a genetic counselor who works at a pediatric institution, I like to see families in person at least once a year with Dr. Listernick. But I'm always available by phone for questions that come up in the interim, because oftentimes things like family planning are not planned around your yearly visit. And then there are some key time points where if you don't have a genetic counselor that you see regularly, you should at least try to meet with them. So anytime you're thinking about having more children, when your child is starting to ask questions and can be involved in that conversation. So, learning about biology in school is a great time to meet with a genetic counselor. And then especially like before high school graduation or in college, starting to enter that adult world to talk more about family planning for the child who's now an adult and their own adult care.
I think that's I particularly that last visit in the pediatric clinic, I think is crucial for a genetic counselor to go, one, to make sure the now adult understands what NF1 is, but and specifically for family planning.
So related to that, this is the big one, and that is there a good time to disclose a diagnosis to a child, NF1, NF2, schwannomatosis? When and if is the right time to disclose? I guess that's for anybody on the panel. And then there's a follow-up question, because there's always a follow-up question.
I'll just take that as a start, because we talked about this at the CTF conference, and I related 2 stories, the second one being a physician parent who wanted their child to never, we couldn't use the word neurofibromatosis, and he was telling her they were going to college every year. And then at some point, she could read that she was going to hospital, and somebody used the word and they stormed out. And I don't think the outcome was very good from what I've heard. So I think, as I said at the beginning of my talk, you give developmentally appropriate information. When the child's 3, 4, you're going to the spot doctor. You can use the term NF whenever you want, and they're not going to go, when they're 5, they're not going on the internet for that. But then you start talking about it when they're 10, 8, 9, 10, using the word and explaining things. I mean, you guys take it up.
Yeah. I also think it is very important to, let the child know what potential symptoms may develop over time as the kid may, in order for them to report the symptom to the parent and then subsequently to the physician, what are things to watch for, and to also make them aware what might happen so that they're not scared. Yeah. And as Bob said, I think the important thing is really to, rather than teaching the name of the disease, really, a good time is always when they start to become more aware and they start to ask questions, what is this? Why do I have this, but my sibling does not? This is a good time to actually start educating the child.
I guess I would agree with that too. And we see patients in our clinic from the time that they're diagnosed, which may be when they're 2 months old or 10 years old, to the time that they leave and decide not to come anymore. And a lot of times when kids are really young, they ask questions, just as Dr. Sykes said, and they'll ask questions about things like, why is it that when I run, I'm not as fast as the other kids in my class? Why is it that I have these spots and other people don't? And those are times to introduce a little bit about NF1, and you don't have to necessarily call it NF1 because that's difficult for younger children. But as they get older, you'll understand your child's ability to understand things, like I said, their developmental, sort of where they are developmentally, and sort of ease into it in that way. But it's best really just to listen to your child's questions and answer those questions, but then bring in education along with that. And then one other thing I'll just add too, so in our clinic, we will oftentimes offer for parents to bring in the kids so that we can talk to them as well. And so sometimes parents want their kids to know what NF1 is or want to know a little bit about it, but they don't know how to start the conversation. So I actually will have visits with parents and kids just for that purpose. And I think it, for some kids, works really well. For other kids, it's maybe not the best way to do it, but certainly ask your doctor too if that's something that you wanted to do.
And I would just add, include the siblings whenever, so they understand the same, in the same exact way.
I'll add a few things. I think what you're hearing universally is don't withhold.
Exactly.
And answer the question asked. Physicians are trained how to answer lawyers in a deposition, and parents can answer similarly. If they ask, what's this spot, answer what the spot is. Don't answer, it's related to chromosome 17 and it has this spot is a spot that you have on your skin. It can't hurt you. That's why we go see Dr. Listernick. We can ask him more next time, but just answer the question asked. And the other thing I feel very strongly about is if we're telling a child they have to go lie in an MRI or meet with a surgeon, we've got to tell them why we're doing that. And in, again, an age appropriate way, what are the potential outcomes? You're gonna have this MRI, it's really loud, it's not super fun, but we can get your favorite whatever afterwards. And it might mean that we don't have to do anything for a whole year, that'd be awesome. And it might mean that we have to go meet another doctor and we're gonna face it together. To not tell a child that and they have to sit through that banging and they don't know why they're doing it, I think that's just unfair. And we want them to not be afraid to see us and not be afraid of the studies we might have to do. So again, the right amount of information in language that's appropriate for the person and at their age.
There's, by the way, a great book out there about MRIs in children. It's called The Donut That Roars.
Oh, that's good. Any difference in disclosure, NF1, NF2? I know often NF2 or schwannomatosis is later in life. Is there any difference in terms of a family, maybe not disclosure, but communication about the diagnosis?
Not in my
No?
opinion.
Good,
no.
okay,
The
just
only
checking.
thing I might say is that we see a lot of children with NF2 early, and that can be its own form of scary, how it presents. The only thing that might be a little different is schwannomatosis. I think we have one child with schwannomatosis. Two. Okay, so it's generally the parent who's been diagnosed, and the parent has children and they're asking how to talk to their children. And I find that a little more complicated because you guys maybe have heard these last few days and today, this morning, about penetrance, and schwannomatosis does not have predictable penetrance and expression. And so that complicates when and how you talk to children who might be affected.
I guess I'll add one more thing. Because we've had some parents with severe complications in familial NF1, and I try and stress to the older kids, to the teenagers or the tweens, that just because your father or mother has X doesn't mean you're going to get X. Because let's say they have a very bad facial plexiform, that doesn't mean you're going to get the same thing.
A team approach, what's your sort of definition, real case of a team approach? And then a follow-up to that, does a team approach, is it a substitute for a second opinion?
So it's not a substitute for a second opinion, I would say, definitely. The team approach is really bringing in whoever you need to make sure the child is getting the care that they need. A lot of times in our institution, it's a psychologist, it's a developmental pediatrician, potentially a surgeon, potentially an oncologist, somebody who knows NF, physical medicine or rehabilitation for the difficulty walking and some of the complications that come with that. Of course, you have to have orthopedics for the bone issues, audiology for NF2 for hearing screening. So it's really a matter of bringing all of the providers together for the child and for what that child's needs are. But I think that, in terms of second opinions, if a family ever wants to go somewhere else for a second opinion, they'll have the team approach at their initial institution, but that second opinion should always be welcome.
I don't think you'll hear anybody up here speak against a second opinion. We ask each other what to do all the time. We're getting our own second opinions. So definitely get a second opinion. I will just say the team approach, as Dr. Bornhurst was just saying, tends to be more global, like your home, your medical home should have a medical quarterback. This is all should. Let me say, it mostly doesn't exist. It needs to exist much more. There are a few places that put in a huge amount of energy and a lot of money, actually, because the medical system is not organized to reimburse a team. That's not how it works. So find a team, stay with that team, because they're hard to build. And when they're built, they're really, the centrifugal force that's holding that together is the interest of the providers providing the best possible care to the people who have a complex situation, meaning the infrastructure that we all live in is not built to create a team. So with that caveat, find your team, and then something's going to come up and someone's going to say, we think you need surgery now, or we think you need chemotherapy now, or we think you need radiation now, or we think you don't need anything now. And that might not sit right with you. And you might say, I feel like we do need something now, so let me go somewhere else. We encourage it so much that I'll say, actually, don't go to Dr. Yohei if you want a second opinion from me, because we tend to think similarly. You should go to Dr. So-and-so, because they tend to think very differently from me. And if you really want a different opinion, it's not going to be so great to go to the person I talk to all the time. We probably are going to say the same thing. So we definitely encourage second opinions. And if you can find a place where they've built a team, like Dr. Bornhorst talked about, all of the professionals that can help maximize someone's care, stick with that place.
About the second opinion, I would just add that if you're ever in a situation where you ask a doctor about potentially getting a second opinion and they discourage you, that's a big red flag.
Yeah, I was absolutely going to say the same thing, Caleb. Absolutely.
And in terms of team approach for NF, sometimes as the patient, it's not always totally visible. So always feel free to ask your providers, who's involved in my child's or my care? Who are you talking to? Sometimes team care is having a meeting once a month where we discuss patients and look at scans together. And at those meetings, maybe 20 different doctors from a whole bunch of different specialties, but you as the patient and the patient family may never sort of have clear knowledge of what happens at those kinds of things. Other situations where there might be a genetic counselor or a psychologist at the same site and you're seeing multiple people, it's more obvious in that situation, but that's just not always how it works.
Or if we are trying to get drugs approved and we work with our pharmacist who help us go through the approval process, that's a huge portion of our team, and you guys don't know those people. So, but that means I think it's a really good point to say to your provider, Who's helping you? Help me.
Yeah, NF is a team sport. If you are in a situation where there's only one person really taking care of you, that's probably not enough, to be honest.
You've answered a lot because that's why y'all are the experts up here. So we're kind of Xing off things as you've done that, which is great. That's great. That's why y'all are amazing. We love you. How about this? We're kind of, I say post-COVID, I guess we're not post-COVID. This is just the new COVID world, right? In terms of where we are. Thoughts on telehealth and NF? When can it be used? When does it need to be avoided? And maybe can you educate us on why telehealth isn't necessarily available for your out-of-state patients?
Can I take, I'll take that.
We check all of our pulses right now. They're all like 190.
Ditto, samesies.
So I think all of us up here probably feel pretty irritated and angry at the moment. So, you know, there was temporary exemption given to physicians during COVID to be able to practice via telemedicine with patients outside of your state. So unlike some professional societies or services, doctors can only practice in states that they have licenses in. So we don't have federal license. We have federal license to prescribe medicine, but not see patients. So legally, I don't have a license in New Jersey. I practice in New York. New Jersey's only about 10 minutes away, but I can't do a televisit with somebody in New Jersey because I don't have a license there. And so that exemption was during the pandemic. They reversed that exemption. So now we're back in a position where you cannot practice in a state that you don't have a license in. I think that this would be a great opportunity for this community to advocate for changing that at a federal level.
And state. It's the states that are holding it.
Yeah. Because this is a huge issue, particularly for rare diseases where there aren't going to be centers in every single town or area. And this is really a great way to improve access to care. It helps with equity in terms of financial parity. It helps with patients who have difficulty just physically getting to appointments. So it's a huge issue, and I would encourage us as clinicians, as well as you guys as the community, to really reach out to your local and federal politicians.
Can I add some facts for your letters? So the reason we can't just have licenses in every state, you'd have to apply to 50 states. You can do that, but every state charges a fee, and every state chooses a random fee. So in the state of Virginia, it's $700 a year for a license. And I know this because I'm in Maryland. We would like to be able to see people in Virginia readily. And so when I went to apply, it's $700. I have to do that every single year. I pay the $700. It takes them 24 hours to license me. So this is not a detail. They are not looking at my medical charts. They are not checking on my skill set. They want $700. Every state is doing that, every single state. So you can write to your state legislatures and say, stop charging these fees or justify the fees, because the 24-hour turnaround, there's nothing, nobody's salary is depending on that 24-hour turnaround. And then we would just apply for all of these licenses. I do currently hold 4 state licenses, but it just becomes financially prohibitive to keep adding licenses. But it's a racket, is what I'm here to tell you, and it is prohibiting care. After the legislative part, what I'll say is, from a medical perspective, it is a wonderful adjunct. So sometimes we're starting a medicine, and I would love to see someone 2 months into being on that medicine to know if they're tolerating it well, just generally see their skin reaction, or any mucus problems in the mouth. But I don't want them to travel 6 hours back to our clinic so I can do a 15-minute check. That telemedicine is ideal for that. Sometimes we're doing a telemedicine and someone's telling me something and I can't get it, and I'm worried about the spinal cord or something, and I say, I'm sorry, you gotta come in. I have to put my hands on your body to know what's going on. But that's still very helpful, because when that's happening, I can say, and you know what, I think we're gonna need an ultrasound at that visit, and I'm gonna set you up to see the neurosurgeon at the same time. So it is a definitely useful tool, but it is restricted to us right now, all of us, because of not smart reasons.
There are definitely things that you can do to optimize your telehealth visit with a provider. So one of the things is it's very difficult actually when you see just through a camera to see like small changes on the skin. So if there are areas you're concerned about, you want your doctor to know, it's great to take pictures beforehand and send those over, for example. It's important to kind of, set the camera up in a way that the doctor is able to see you. And that's particularly important when you try to examine a child, virtually. So when we ask them, for example, to kind of walk on their heels, it's not helpful if I actually see the face. So there are those like, there are these things that everybody can do, the patient can do to just optimize the benefit that you're getting out of such a televisit. Yeah.
And I would agree,
And
telemedicine.
Oh, sorry. And I think there is an excellent YouTube video, I think by Dr. Yohei, like life hacks or something like this. Yeah, I think he has gives some very helpful tips there, what families can do to help actually.
I'd just like to add that telemedicine is a really great way to see your providers who are talking specialists. So as a genetic counselor, I'm not going to do an exam, right? We have a conversation, and it's really wonderful to have an hour uninterrupted where we're both in a quiet space and we can just talk to each other. So I love seeing patients by telemedicine.
I was going to add that too. I think so for our psychologists, for example, it's really nice to have those visits via telemedicine because it is uninterrupted and it gives you an opportunity. And actually, I think a lot of kids feel more comfortable when you have a screen between you and the counselor versus having them there in person, although there are some people who really prefer that in person too. And I mean, I would advocate too. I mean, I know telemedicine is hard, but I also hold 5 licenses so I can do it. And so it's a yearly thing, and I want it to be an opportunity for families. And so we do our best to try and offer this. I think if you're a new diagnosis, it's not the best. I've had at least a handful of kids now who've been misdiagnosed because of telemedicine, because you just can't see spots. You can't see how many are there. And I've had a number of kids that have been told you don't have NF when they actually do, just because we couldn't see the exam well enough. And then if there's a new complaint, that's also a reason for you definitely to come in. If your child is feeling a little bit weak on the right side, as Dr. Blakely said, we have to do an exam because we need to know exactly what's going on. And then the third thing I would say is that for your annual exams or your every few year exams or however often you're going in, it's also best to go in because when we see you, there's a lot of things we check off and we're trying to make sure we're not missing something. And so some of those are hard to catch over telemedicine as well.
So a follow-up question, maybe a little bit to that. How often, or does it happen, where maybe 2 doctors of 2 different specialties are in the same room at the same time with the patient talking about the care? Because I've been from one appointment to the next appointment to the next appointment, and you may get sort of different takes from different specialties. Does that ever happen?
Well, I can only say that and I think Caleb alluded to this, we try very hard as a team to give a unified opinion. Because I don't think it helps personally in one hospital visit to have one, the ENT physician say one thing and the oncologist say something else. So as a team, we're very careful about giving one opinion. I think Caleb was alluding to our brain tumor board. And it's very rarely things are black and white. Really, they're not black and white, and they're gray, and we will tell you it's gray, but we will still give you our institutional or our team opinion.
Yeah, and there sometimes is disagreement within institutions, and tumor boards and discussions like that are a great way to sort of air that out and get the discussion, more broadly addressed by a whole group of people and try to come to some consensus. I will say at our institution, it's pretty rare, but not never, that actually 2 different physicians of 2 different subspecialties are in a room at the same time talking with a patient. And for a variety of reasons, that turns out to be, I've found that to be challenging to work out in my NF clinic on a regular basis, in part because there are some conditions where people need to see the same set of subspecialties on a very regular basis. And so everybody with a particular condition might need to see a orthopedist and a neurologist. For NF, some people need to see an orthopedist, some people need to see an oncologist, some people need to see a neuropsychologist, some people need to see a physical therapist. So you can't have 30 people in the room at the same time. That's not financially feasible, physically possible. And it's actually a miserable experience for patients, in my experience, where I have been involved in some clinics that are similar to that. And you end up feeling, or my impression of how that feels to patients is that you feel a bit like you are an exhibit or a zoo attraction, because you're having all these different people like come and sort of look you or your child over and then move on, and it's a little bit weird.
Yeah, so to answer the question, how often are two physicians in the room together? Once a month. But it's exactly as Dr. Yohei just said, we plan that clinic very carefully, and it's neurology, neurosurgery, and genetic counselor. And we've chosen who needs to come in for that set of people. And then on that day, we are there together. And frankly, I would say we practice together. I would say 90% of our patient visits, we have all planned out before you're there. We're waiting for you to tell us the rest. How do you feel today? What does the exam look like? But we've already thought about what MRIs we might need or not based on what we knew last time. And so the in the room together, we can do, but in a very thoughtful way. Otherwise it's chaos. The key is those tumor boards. Those tumor boards are where we synthesize the opposing opinions and then can come back to you to say, here's why there were opposing opinions. This one thought this, and here are the pros and cons of that, and this one thought this. And in the end, our final recommendation is why.
And actually, just one quick plug. So the Clinical Care Advisory Board has worked to put together a clinical care conference once a month. Each month, it's sort of based on what a tumor board at an institution is like, and a case or two or three are presented, and there's discussion from experts all over the country. And the point of that meeting once a month is for clinicians to learn how other clinicians are thinking about NF. So it might not be a bad idea if you guys told your doctors about this opportunity for them to actually hear how those discussions go and see how people think about different diagnostic and therapeutic challenges.
So in our last 5 minutes together, I'm going to ask you to be negative, but end on a positive. What are the most challenging patient or parent practices you encounter? And what are the best practices with patients and parent caregivers you see?
Oh, you're asking.
You have to answer.
I would say
I can go first.
challenging is when we can't get people involved. When we see a problem and we can't get the follow-up, or we can't get especially on the ped side. On the adult side, that person is making their own choices not to follow up. But when you can see the car wreck coming and you have a plan to intervene, and we can't make that happen. From a interpersonal perspective, let me tell you, all the time there are systematic things that get in our way of preventing the car wreck, but we can work around those. But when the person doesn't want to engage in their own care, that might be the most heartbreaking, frustrating.
Yeah, I was just going to say I have the similar answer. For both of those, my answer is communication, because communication can either completely derail things or it can make everything a success. And that's communication between family members, between parent, child, siblings, but also communication with the team. And so the better we're all talking to each other and listening to each other, hopefully the more successful we'll all be in caring for the patient.
I'll be a little, I don't know whether it's provocative. I find everything challenging. I find because it's not because a lot of what is not black and white in NF care, there's always discussion involved. We're hoping with multiple studies that are being done to try and answer these questions, but still it's very gray often the time. And I struggle with making recommendations because it is gray. It's really nice to follow, the new thing in medicine is clinical pathways. which I'm guessing the older people don't particularly like very much, me, myself included. But it would be nice to say, in this circumstance, this is what you do, in certain circumstances in NF care. But the problem is, it's still gray, and we're learning every day, and we're hoping to make it less gray or make it more white, put it that way.
I'd say some of the best things that families can do is similar to what you've already heard, but active involvement, but patience at the same time. Sometimes we are doing a lot of work behind the scenes and getting lots of opinions, and sometimes, especially if we're not communicating adequately, that can seem like, nothing's happening, when in fact a lot is happening. So, but stay actively involved, ask questions, check in, that's totally fine. But also give us a little bit of space and time.
Yeah, and that on the best experiences. I mean, why are these people here? It is Saturday, right? Yeah, okay. I am. It's a Saturday. We have. I have 18 notes I have to close before Monday. It's because of the relationships. So it is the best and the worst. So when we can't get a relationship going, it feels terrible. When you have a good relationship, you'll fly to Chicago and be here on a Saturday. It's totally who said it? Like, we're part of your family. Sorry if you didn't know that, but we care deeply, and that makes it all worthwhile.
Well, that is a great ending. I know we're out of time, but I guess our action items are, you're going to be honest with us, and you want us to be honest with you for that relationship. So
And call your legislatures.
absolutely, absolutely, I'm ready. It's time to get back in those offices for sure. So thank you all so much for your candor, your transparency, and for your support. Yes, please.
Are you guys aware of any other disease that has successfully done this telehealth legislative thing that we can go learn from?
No.
It's just the care.
It-
No, are they doing something cool?
Like if you work inside the VA
Yeah.
system.
Oh, I'm sorry.
Yeah.
So the question was, is there any other disease organization or disease space that has successfully won this battle, this telehealth battle? And Tracy, we need microphone.
Do the exam.
No, you need microphone.
The ophthalmologist, Tracy says the ophthalmologists have successfully done this?
Yes, I see ophthalmologists from, I do telehealth with the ophthalmologist in Seattle. And I've done them and they're well-known. So I don't know how they're getting away with it.
So they're either breaking a law, which, I mean, we're probably not going to be prosecuted for breaking the law, but it doesn't feel great. I don't tend to break laws, so.
I'm going to ask them because
Or they've gotten a license to do that. So like we have extra licenses to allow us to see patients that are our highest volume outside of our state, but we had to go apply for those. But so there are two problems, just because I want you to go talk to your legislature. There's a federal law that speaks to this. And one thing that happened, I think that's going to be permanent because of COVID, was the billing. So Medicare and Medicaid used to not allow interstate billing, and that has resolved, and I believe that that's permanent. And that's under the federal administration to do that. There is, every dean of every medical school, every hospital wants there to be telehealth. So there's been a big push from like the American Academy of Physicians and so forth towards that end. The problem is it's driven by each state, and I don't know what proportion of money that brings in having these licensing fees. It's not only physicians, it's nurse practitioners, PAs, genetic counseling, physical therapy, occupational therapy. We all pay a licensing fee every year. That's generating some level of income at every state. And so to get rid of that, the states have to agree to give up on that.
One thing I'll say too, though, is that you can actually get second opinions a little bit differently. And I think that could be a way that they're getting around it as well. So if somebody, let's say somebody wanted an opinion on how to treat their plexiform neurofibroma, and they lived in a state that I'm not licensed in, I can actually see that patient via telemedicine, but Also, I have to have communication with their provider. And so I can talk to the patient, get information from the patient, but my actual opinion has to go not just to the patient, but also to the provider. So I'm not giving you medical opinions
You're not taking
myself. I'm not,
responsibility
right,
for
I'm not
medical
taking
care.
responsible for it. I'm just talking with you so I can better advise your doctor, who will then be the one making the decision. So that may be another way kind of that they're getting, or people are getting around it too. But I mean, there's definitely, there's a lot of push to do this in a lot of other communities. I know, for other cancer predisposition, Li-Fraumeni syndrome and some other syndromes, I know that a lot of the parent groups are advocating for this. I just have not heard of a group that's been successful yet. And I think we would have known about it, because if it's successful for one disease, it would be successful for everything. It's just a licensing issue more so than a disease specific issue.
Thank you.